Hi everybody, this is Trevor Shaw, and today we are going to discuss the corrective exercise plan for a 37-year-old female client. The history for this particular client includes the fact that she is a 37-year-old mother of two with a chief complaint of right hip pain and left shoulder pain, both of unknown etiology. She has a history of a left metatarsal fracture about 16 years ago. She's a non-smoker, a social drinker. She has a very high-stress job on her feet all day, averaging about 12,000 steps per day as a surgical ICU nurse. The patient's goals were to eliminate the right hip pain and right shoulder pain, but also to lose 10 pounds. One thing that we don't have listed here that you'll see come out in the exam was also to improve balance on the left side. She felt that her balance had suffered greatly from that left metatarsal fracture 16 years ago. For the lower body exam, we selected the overhead squat and the single leg balance test. For the overhead squat, we had excessive forward lean in the lumbopelvic hip complex. The shoulders fell forward, the low back rounded, and there was an asymmetrical weight shift. But probably the most prominent dysfunction that was noted was the bilateral knee valgus translation. For our single leg squat, we had a repeat of the bilateral knee valgus translation with the knees moving inward bilaterally. But probably the most prominent thing that came out here along with the bilateral valgus knee translation was the fact that left leg balance was a huge problem for her. Breaking out the overhead squat, we elevated the heels so that we could isolate whether this was an ankle or hip issue. When we elevated the heels, the squat pattern did not change, so we put most of our focus into the hip complex versus the ankle complex. One of the things that you'll notice throughout the course of this presentation that we talk about quite a bit was one of the things that was missed in this exam particular in the overhead squat was the function of the foot. By elevating the heels, we take the ankle in or out of the equation, but it doesn't tell us much of what's going on at the foot. That single leg balance test is really where we got a lot of the information along with the chief complaint about how to deal with this foot issue. For our upper body test, we performed Davies test, we performed a rotational test, and then the shoulder flexion test. With the Davies test, you can see that the outcomes were pretty consistent all the way through. For the rotation test, she definitely had internal shoulder rotation, and for the shoulder flexion test, she arched her low back to accomplish the goal. From her dysfunctional tests, we were able to take that information and apply it to the NASM textbook, where we were able to derive our overactive versus underactive muscles. I'll spare you reading through each one of these, but I'll give you time. You can look through this table and see exactly which muscles we decided to use SMR and the lengthening techniques on versus our activation techniques. This client did present with some extenuating circumstances, things that we like to call perpetuating factors, things that aren't typically discussed in the corrective exercise continuum, but are extremely important to deal with, almost just as important to deal with as the physical ones. For this client, she had a lot of psychosocial perpetuating factors. She really wasn't committed to the corrective exercise concept. She had been used to bodybuilding and fitness style workouts. Once we explained to her exactly the importance of decreasing the risk of future injury and how that would benefit her in the long run, her buy-in was better, but still not great. She had low enthusiasm for the proposed plan, but she also had a lot of fear avoidance of loading the lower extremity in the squat and single leg patterns due to that history of foot fracture. She just complained that she didn't feel stable and she felt very uneasy getting into some of the lower positions. So from there, we designed a plan of attack. Basically, the focus was going to be on the most dysfunctional pattern, which was the overhead squat, specifically the valgus collapse of the knees, because that presented on both patterns. We needed to approach this in a graded exposure fashion due to the psychosocial yellow flag involvement. We couldn't just jump right into high volume, high intensity exercise because she was scared of loading those deeper patterns. So what we decided to do was monitor biweekly outcomes and progress and decide if we were going to progress or regress each time. We programmed a re-exam at the 1 month mark, and we were going to decide at that point whether we needed to implement any specific foot exercises for this patient. We really wanted to see if the NASM guidelines for attacking the lumbopelvic hip complex would get us our answers first before diving into the foot. The next series of slides is the program design. What you'll notice is that the graded exposure model really demands that slow and steady wins the race for these particular clients. You'll also notice the progressions are made in intensity of the SMR lengthening and activation techniques. Notice the volume and intensity slowly progresses upward each week. The position of the bands also goes from above the knees to below the knees to stress the lateral hip musculature just a little bit more. There's evidence to support that, cited at the end of the paper or the presentation. The functional exercises progress from more common or from more NASM style exercises to more compound lifts that the client was much more comfortable with, such as deadlifts and kettlebell swings. We just felt like taking our time to expose her to that would yield the best results. So in concluding the 4th week of training, we had programmed a re-exam. And the goal of the re-exam was to see the improvements of the knee translation, but also to decide whether we had to examine the foot. When we redid the overhead squat, we noticed a 25% improvement in the valgus knee translation. But when we came to evaluating the foot, there was a noted functional arch loss, which I'll go into in a minute. There was navicular drop and really inability to control the intrinsic muscles of the foot, which we tested with an exercise called the short foot exercise. So in conclusion, there was improvement, but continued lateral hip and glute weakness, and there was intrinsic foot weakness. So then the plan shifted to increasing intensity at the hip and implementing these foot exercises. To perform the short foot evaluation, the first thing that we do is we have the client stand on a hard, flat surface. We evaluate the height of the arch to determine navicular drop side to side. We didn't break out the measuring stick for this one. We simply evaluated via eyesight, and you could tell that there was a difference from left to right. The next thing to do is to evaluate functional arch integrity. To do this, we have the patient then just simply elevate onto their toes. Now, if that arch integrity improves, we deem that a functional arch loss, something that we can train. So the next series of tests become the short foot tests or the short foot exercises. And all we're doing here is evaluating the client's ability to perform these on the test, but then the test becomes the exercise later on. So what we have the client do is just see with the foot flat on the ground, can they make the distance between the metatarsal heads and the calcaneus as short as possible by elevating that arch. If they can, we ask them to hold that for 10 seconds. The next position is, can they dorsiflex the great toe and hold that for 10 seconds while the rest of the toes remain flat on the ground. The third exercise is to elevate toes 2 through 5 and see if they can keep those elevated for our 10-second mark while the great toe is relaxed on the ground. We follow that up with toe AB and adduction, and we have our 5 short foot exercises. The client was able to navigate these exercises with quite a bit of difficulty, but able to navigate them on the right side. She had almost a complete inability to do the exercises 2 through 5 on the opposite side. So the left foot needed a lot of work, and that's where we started adding in some more exercises for her. So the biggest change you'll notice from week 5 on was the addition of the short foot exercises. This is really the finishing touch on the program to deal with the foot issues stemming from that metatarsal fracture years earlier. Doing so at this time allowed us to use a process of deduction versus a shotgun approach to her treatment. Had the client responded well to the hip therapy alone, the short foot exercises would not have been needed at this time. However, that was not the case. Despite making great gains with the hip corrections, making a 25% improvement in that valgus translation, she simply needed her feet to be addressed as well. So we programmed her short foot exercises to be done on her Tuesday, which was her training session alone, which also had her shoulder work involved, so as to not lengthen the duration of our visits together. So let's discuss some literature on the program as we're concluding this presentation. What we know is that decreased lateral hip strength has been implicated in chronic hip pain and valgus knee collapse in multiple papers. For this reason, it was the point of focus for our program. The client was then led through a progressive exercise program that began with bands above the knees and progressed to bands below the knees, while also progressing from non-weight-bearing exercises to weight-bearing exercises in an effort to increase the lateral hip musculature involved. We have literature from Cambridge and Cochrane to support the idea that moving the bands in that particular manner does increase the load on the lateral hip, and that moving from non-weight bearing to weight bearing exercises increases the load on the hip as well. So that's why we decided to go that route with this client. So as for literature supporting the foot, the short foot exercises were added post re-examination to handle the foot instability issues suffered from the metatarsal fracture 16 years ago. The client felt greatly affected by her balance or lack of balance in her single leg stance and stability on that left side. Solowaska has shown that these exercises actually improved foot strength and stability in runners, so that gave us justification for implementing them into our program. Strengthening the feet has also been shown to improve global movement patterns up and down the kinetic chain. It makes a lot of sense, even when you look at pronation syndrome in our NASM book, how that affects global movement patterns all the way up the chain. So that's why we implemented those. As for challenges in the learning experience, there were a few. The two biggest challenges were the yellow flags and psychosocial aversion to the prescribed program, which we had to navigate with graded exposure and building that client up slowly to the patterns that she was not confident in or that she anticipated having pain in. In the rehabilitation world, the concept of dealing with this is that hurt does not necessarily equal harm in the chronic pain patient. So we have to really expose them slowly to these exercises so that they know that, hey, just because it hurts doesn't mean that I'm injuring myself more. And breaking that negative mental cycle can be a huge hurdle for these type of clients and these type of patients. So that was a challenge. It's always a challenge, but it's always a fun challenge and hugely rewarding when you can get clients over such a hump. As for learning outcomes with implementation of the corrective exercise program, one of the things that just reaffirmed itself over and over and over again was specificity matters. Along with the global movement screen, local biomechanical testing goes beyond basic orthopedic testing. When we do orthopedic tests, we really are looking for problematic tissues, sprains, strains, or joint dysfunction. Our local biomechanical specific corrective exercise testing can tell us how those muscles are moving and functioning and how they're rooted in the CNS for preferential movement. So that's a big thing that I took away from this was just, take your time and be specific. The third thing that I learned, and that always seems to be a factor, is the psychological state of the playing or of the patient. The psychological state of the patient dominates the playing field. If they're not into it, you have to figure out ways around it. If they have fear avoidance beliefs of certain exercises, you have to take that graded exposure approach and slowly introduce these exercises to them so that they realize that hurt doesn't necessarily equal harm. I know that's outside the scope of some of the people in this class. However, it's a really, really good thing to know because you can work side by side with clinicians to get the best answers for your patients. And then going along with that is slow and steady wins the race here. We don't have to be in a huge rush to progress exercises. Variety is the spice of life, but with corrective exercise, we do want to take our time and make sure that the patient is getting the most out of each thing that we prescribe for them. So finally, how could I improve upon my learning experience? Had I been able to go back to square one, I think I would have done more manual muscle testing and been hyper focused for the corrective exercise plan. Um, I think in overlooking some of the muscle testing, I may have made the program a little bit too beefy and too time consuming for this patient. However, worst case scenario when that happens is they spend a little bit extra time doing exercises that they may not have needed as much. I felt that this was a better approach than to try to narrow it down so much that maybe I overlooked something. We already saw that the short foot exercises got pushed all the way out to week 4. Would this client have made much better gains had we implemented that short foot exercise program in week 1? Your guess is as good as mine. Maybe it would have clouded the outcomes of the hip and we wouldn't have progressed the hip the same way. So overall, I think I would have implemented the muscle testing a little bit more, but I don't have any regrets about how we approached this particular client. I think it worked out great in the long run, and she was extremely happy with her training program. And in conclusion, I just wanted to state that I felt this was a very valuable learning program. I felt that taking the time and being super specific paid out in the long run. The client met her goals or is on track to meet her goals of her 10-pound weight loss. Her hip pain has improved significantly overall. And even at this point, even though she has a few days left of her program, she has made tremendous gains as far as her hip and shoulder pain. The squat patterns are starting to look significantly better and her balance is improving. So overall, this was a successful program. Thank you for listening. Bye.